Thank you, Chairman. So this morning we had many inspiring talks, like from Ramesh, about the future. Now you're going to hear about what we did in the past. So that's my declaration of conflict of interest. Okay, just to set the stage for the main topic, I just wanted, for those of you who have not been to Vancouver and not used to the Canadian system, I just want to explain a little bit of how we are set up in terms of cancer care. So this is Canada, and we're the Northern Mexicans, as President Trump calls us. It could be a wall along here pretty soon. And Vancouver is in the southwest corner of province of British Columbia. And this province, about 4 million people and inhabitants. Most of the people live in the southern part of the province because it's warmer down here. And we have basically 6 cancer clinics that delivered cancer care to the whole province. And this is where the radiotherapy machines are located within the cancer clinics. So the Vancouver is where I work, but within a fairly short distance, within the sort of greater Vancouver regional area, there's actually 3 clinics. And then there's one on Vancouver Island in Victoria. There's one in Kelowna, which is in the southern interior part of the province, and then a small clinic up north in Prince George. So you can see we basically have a captive audience of about 4 million people. All cancer care is delivered through this single organization. We don't have a lot of resources like a lot of American centers, but what we do have is numbers and consistency of treatment. And we're pretty big on sort of reporting population outcomes, things that you can achieve in reality within a community rather than in a research study where things often look better because of some patients are not eligible for clinical studies. So our neurostereotactic radiation program was started about 20 years ago. It was a collaboration between our department and the Department of Neurosurgery at the Vancouver General Hospital next door. And we started with single fraction radiosurgery for brain tumors. And it's really a multidisciplinary team. This list is not exhaustive of all the doctors involved, but the idea is to let you know that there's radiation oncologists, there's neurosurgeons, increasingly skull-based surgeons, orbital surgeons, medical physicists, neuroradiologists, and of course radiation therapists. And every week we have multidisciplinary conference to review all the cases from around the province. As you can imagine, brain metastasis, especially with all these now lung cancer patients of ALK mutation and EGFR mutation, we're getting more and more brain metastasis, lung cancer patients that are looking for focal treatment rather than whole brain treatment. But then also a variety of benign brain tumors like acoustic neuromas, meningiomas, pituitary tumors. So that's kind of the stage where these patients come in through. And I'm going to now concentrate on a specific topic of the optic nerve meningioma and what we have, our outcomes over the last 20 years or so. So the eyes, the globes, embryologically derives from the frontal lobe of the brain. When the eyes comes out of the brain into the orbit, it drags a cuff of meninges along with it. And this is why you can get meningiomas in the optic nerve as well as the rest of the head. They're primarily classified into 2 types. The primary optic nerve meningiomas are the ones that are completely confined within the orbit along the optic nerve. And you can have secondary optic nerve meningiomas, which primarily arises from the lateral wall of the orbit, which is the sphenoid wing, and it grows around and into the optic canal and involves the optic nerve this way. In terms of presentation, it's a classic clinical triad. The patients present of visual loss. On examination is optic nerve atrophy and presence of shunt vessels. Because these meningiomas are highly vascular, they tend to steal a lot of blood from the nerve. Surgery is mostly historical. back in the days when we didn't have CT scan and MRI, surgery played a bigger role in terms of making diagnosis and even treatment. But what the orbital surgeons have found is that with attempted resection or even just partial debulking of the tumor, there's a very high risk of immediate visual loss. So this is really not something that is considered much nowadays. Most of our diagnosis is based on imaging. So the cohort that we recently analyzed and published is from the era of 2001 to 2012. So these patients were consistently reviewed at our multidisciplinary conference, and after treatment they were consistently followed by us with MRI imaging and also with a neuro-ophthalmologist for visual field and visual acuity assessment, as well as ocular toxicity. And we perform Kaplan-Meier actuarial analysis in terms of tumor control and visual outcomes. This is the breakdown of in terms of the tumor's location. Just over half of them are primary tumors confined to the orbit, and 18 patients there were secondary tumors. Most of the patients are between 41 to 60 years old, and most of them were male. About a quarter of the patients, the subjective complaint was actually double vision, because when you have a mass in the orbit, it interferes with the ocular motor muscles. There's often some headache or at least ocular pain because there's a mass behind the eye, and you can have proptosis. In terms of visual acuity, it breaks down to about a third, and a third. So about a third of the patients have pretty good vision at the time of presentation. So between sort of 20/20 to 20/30. Another third is up here, which is moderate visual loss. And then about a third, which is worse than 2200, this legal definition of blindness. On examination, most of them will have a relative afferent pupillary defect, which is a hallmark of a second nerve problem. On Goldman visual field, there will be visual field deficits in 59%, and about a third also have impaired color vision, most commonly what is called red-green desaturation, which is that when you look at something red, it looks green. That's a very sensitive test for a second nerve problem. So in terms of the treatment, only a minority had some sort of surgical procedure, only 8 patients. Because there was some question about the diagnosis on imaging. Often it's a biopsy. There's very few that you need to do any sort of subtotal or resection or debulking. And uniformly, our cohort of 40-odd patients are treated with stereotactic radiotherapy using our LINAC, which is modified for SRT use. Our prescription dose is 50.4 gray and 28 fractions prescribed at 100%. And I'll go into a little bit more detail about the planning. The immobilization mask is made by BrainLab in Germany. As you can see, this is a kind of an oyster shell type of mask with back occipital half and the front half of a carbon fiber post climbing on the side. There's 2 layers of thermoplastic mask over the frontal area as well as the maxilla, and then there's a bite block that limits the amount of movement within the Z direction. So this is a pretty rigid immobilization. In terms of beam shaping, we have 3 millimeter micro multileaf collimation from BrainLab as well. And the GTV is defined as the gadolinium enhancing tumor on T1 sequences. We do dedicated MRI and fine cuts for SRT planning. And the CTV is a 3 millimeter margin along the optic nerve and also the plane of the dura. And we give a 2 millimeter margin from CTV to PTV. Now, our prescription was 50.4 gray and 28 at 100%, but only 90% isodose is actually covering the PTV. So this is a relatively modest dose of radiation, 45 gray and 28 fractions, mostly because there isn't a lot of data to show that dose escalation with meningioma is very useful in terms of tumor control, and we're quite concerned about ocular toxicities. So in our earlier cohort, up to 2008, we mostly use multiple non-coplanar conformal beams to treat these tumors. So anywhere between sort of 6 to 8 beams in non-coplanar manner to treat the tumor. And you can see that the lower isodose here, there's a little bit of a horn here, 30%, because of the fixed beam configuration. Later on, as we got dynamics arcs commissioned, this is the preferred technique. So this is when as the gantry is arcing through the PTV, the leaves will move and conform to the shape of the PTV in that cross section. Usually 3 to 4 or 5 arcs, something like that. And as you can see, the high dose volume is quite similar to the fixed beam, but the lower isodose is now much more smooth, and you lose those horns that were peeking out. In terms of side effects during treatment, because you're putting these beams through the frontal lobe and through some of the sinuses, patients will get some headache. About a third of them get some headache, but not severe. Nothing that some Tylenol or something like that cannot take care of. Some patients get a bit nauseated, although it's rare. It's also rare that they need any sort of Decadron to relieve the symptoms. We try to limit the dose to the anterior ocular structure to less than 10 gray. So 10 gray and 28 fractions is a pretty low dose. But even that, a small proportion of patients do have radiation-induced conjunctivitis and keratitis. So in terms of local control, it's actually very, very effective, as you can see. So these are actuarial 5-year figure, but we have such a long follow-up that these are actually true numbers. It's not projected out. We actually have not had a case of tumor progression in the primary nerve sheath tumor. It's running at 100%. We lost a few patients with a secondary tumor, but even that 88% at 5 years is very, very good for such a modest dose of radiation. So in terms of the relapse of the couple of patients that were secondary tumors, one was salvaged with surgery, no recurrence, and then one died of an intercurrent illness that was not related to the tumor. We looked at those 2 patients. This is one of them. So this was the original planning CTV, and this is the area of relapse on subsequent MRI. And you can see that actually the area of recurrence was within the original 90% isodose. So this is not an edge recurrence. It actually recurred within the high dose volume. This is the other patient, once again a secondary tumor. This is the CTV. The area of relapse laterally, and also is it still within the 90%. So similar idea is an infill recurrence. So the message I guess I took away from that is that, when we first started out with a 3 millimeter CTV margin, GTV to CTV margin, a lot of people are saying, you're doing too skimpy, you're going to have edge recurrence and stuff like that. We don't actually have an edge recurrence. You don't have to go far and wide to chase these meningiomas. But perhaps because the bigger bulk of the secondary tumor, our modest dose may not be as effective. The primary tumor that within the orbit, the PTV volume tends to be much smaller because they are within the orbit. And 45 gray seems, it's 100% control, so I don't think you need to dose escalate. But maybe for these secondary tumors, we should maybe increase the dose modestly to get the last couple of patients. Now, on the flip side, obviously, if you increase the dose, you increase the risk of toxicity. And so now we're going to talk about the outcome, both in terms of visual acuity and ocular toxicity. So what we find is that 2/3 of the patients, we were able to preserve the vision at whatever level they were diagnosed with. About 1/3 actually improved, and only 7% had worsening of the vision after treatment. So if you're like a medical oncologist and you say, you know, stability is a good thing already, you got 93%, I mean, that's an A+ if you do an exam like that, right? In terms of visual field defects, similar, actually quite similar finding. About 2/3 have stability, about 1/3 had improvement, and 8% had reduction. So once again, about 92%. So that's pretty good. So if you work out the actuarial visual preservation of both the acuity as well as the visual field, once again, the primary tumor tend to do a lot better. We're running at like 100%, whereas the secondary tumor, there's a little bit of a drop-off at 5 years. So those are the ones you need to increase the dose probably for tumor control, but then we're not doing as well in terms of the visual preservation either. So those are tougher tumor to treat. In terms of late toxicity, very, very few. Some of these tumors do extend quite posteriorly close to the pituitary fossa. So the pituitary gland gets a little bit of radiation as an innocent bystander. And we routinely send them to endocrinologists for baseline pituitary testing and annual follow-up. And we found that 7% have at least one of those pituitary axis hormones that need to be replaced on a long-term basis. These usually happens 2-3 years afterwards. It's quite a delay side effect. 7% have retinopathy. These are usually the tumors that go right up against the back of the globe. So your PTV is including the back of the retina. There's no way to avoid those. And then a few patients have cataract, which may or may not be related to radiation, and some have some unexplained ocular pain, but not sure exactly why that is. So in terms of conclusion, so we now think that, you know, SRT in our institution is the standard of care for optic nerve meningiomas. The orbital surgeons are very happy to just send them to us and get them treated without tissue diagnosis or without any attempt for surgery at all. We have good long-term control in terms of at least the primary ones. The secondary one is probably could be improved with a bit of dose escalation. Visual preservation, at least stability in the majority of the patients. I just want to acknowledge my co-authors in this paper, Dr. Sarah Hamilton, who was our resident before, now is one of our staff, and Dr. Peter Dolman, who is one of our orbital surgeons colleague. Thank you very much.